Alrighty, we are back. This is the very first CareOps event in 2025, and it's a very cool one and also a new format that we are trying out. So thank you, Pia, for being our first guest here that will give an actual keynote/presentation to the audience about something very fascinating and something that you are very passionate about and hope to see, and something that I hope to see more in the industry as well. So while we wait for more people to trickle in some context, so I met Stephanie, which is the CEO of Boulder, a very long time ago. She was actually one of the first subscribers to CareOps. We invited her to be on a panel, and then due to some reasons, Dave, which is also a founder of Boulder, was on the very first CareOps panel as well. We stayed in contact. I think Stephanie and the team replies to almost every email that we send with CareOps. And then for the CareOps conference, we have Rose, which is a CEO, coming. And she said, like, if there is one person that you should have on a panel or on a discussion in 2025, it's Pia, but she will probably say that she's not good enough or smart enough for this. But obviously, you definitely proved me wrong on that. And so for background, me and Pia spoke a few weeks ago about the popping clinic for a very long time. She was very fascinating to talk about this model, and I was very intrigued by this model as well. And what I even liked even more was that Pia doesn't come from like the typical healthcare operation background. So Pia worked at Nike, she worked in like logistic companies, warehouse operations. She even worked in VC for 2 years and then eventually joined Boulder to now be the VP of operations. So I'm really, really pleased to introduce Pia to you all and the keynote that she will be giving. Before that, quick intro on myself. I am Rick. I'm an RN by training, work at Sort as a product lead. And with me, I also have Thomas, which I will also introduce himself.
Hi, Thomas, co-founder, CEO at AWell, and together with Rick, co-author at CareOps. Great to see you all.
Yes. So format for today, Pia will give a keynote. After that, we will open the floor for Q&A. If you have questions in between the keynote, you can already put your questions in the chat or in the Q&A. And then we will probably pause at some points or some slides that we are like, okay, now we really, really want to ask a question. So the floor is yours.
Thank you, Rick. I'm so excited to be able to share this story, and thank you for the lovely intro. I'm going to try to do you justice here. Rick, you mentioned my background outside of healthcare. I just want to say it's been such a privilege to bring that experience to Boulder Care and use it to scale our care model in really innovative ways. And so I'm here to walk through one of our major innovations today. And I want to sort of inspire others to seek to innovate in these sort of unexpected ways. So I'm going to dive right in. Let's talk about no-shows. So all over healthcare and including at Boulder Care, missed appointments or no-shows are just a really thorny issue. At Boulder Care, we treat substance use disorder, which means that no-shows aren't just a revenue or efficiency problem for us. They can be catastrophic for our patients. When patients miss their appointments to refill buprenorphine, which is a medication for opioid use disorder, it can be catastrophic. Without those meds, patients can experience withdrawal and potentially return to use and possibly overdose. And especially in the age of fentanyl, those stakes feel very, very high. So today I'm going to walk through how we solved that problem by creating what we call the Pop-In Clinic. I'll tell you why we decided to try it, how we tested it and ultimately launched it, and where we are today, just a little over a year later. And then, Rick, I'm going to try and get into the nitty-gritty along the way, so guide me there where you can. But I want to give you just the briefest of backgrounds on Boulder Care and sort of who we are. So at Boulder, our medical team treats opioid use and alcohol use disorders using a combination of peer support and medicine. And again, I mentioned this, primarily that medicine is buprenorphine. And our mission, in a nutshell, very paraphrased, is all about access to high quality care for those who need it most. And so that means that my mission at Boulder is to get that care to as many people as possible, as quickly as possible. So you can imagine how we get to something like an on-demand clinic from that. So I want to take you back to 2022, where this all started. In early 2022, we were in the very fortunate position of knowing we had a care model that was rock solid. It worked for our patients. We had great outcomes, and we were also bringing payers to the table with these innovative contract designs. So we were on the right track and we knew it, but we hadn't cracked the code yet on how to scale that care. And that was what I and a lot of others spent a lot of that year focused on. We sort of started with the standard playbook. I'm not going to spend a lot of time here because I assume that most of the people on this call have done this work before and know what it takes. And, it's things like standardizing our care model, making everything more streamlined and predictable. It's cutting unnecessary charting, administrative tasks. We were able to move from 30-minute visits to 20-minute visits as a result of this. We were incredibly controlling about our clinicians' calendars. We were tightening up admin time and, making sure that not a single minute went unscheduled. And of course, along the way, we were integrating more and more tech to make our team's jobs more efficient. So I'm sure you've all been here before. We've all done this. It sounds familiar, and there's a reason for it. It works. We were seeing major improvement in cost of revenue without sort of negatively impacting our care quality. But this wouldn't be a very interesting story if it had worked that well. There were still problems, and we were finding that this standard playbook could only get us so far. We had actually exacerbated two of our most critical issues. So while we were doing all the right things, we were making things worse, not better, in a lot of ways. So first, back to no-show rates, right? They were 30 to 40%. They were sometimes higher than that, and our teams were so burned out. They were struggling with these jam-packed calendars. And like we said, missed appointments can be catastrophic for our patients. And so when a patient would call trying to get in and make sure that they could get their medication after they missed an appointment, we had nowhere to put them. Our care teams were struggling with this, our patients were struggling with this, and it was all sort of starting to explode. And then I want to talk about the other side of this problem. We have a North Star metric that we call time to balloon. Yes, we borrowed this from cardiac care. It is, for us, the speed with which we can get a patient into care once they've reached out to us. It's a really important metric for us to get patients in quickly at that moment that they reach out. And our target is always 0 to 2 days, has been from the very beginning. As I was doing all the things I thought were the right things to make things more efficient, this number was actually rising. At some point, it hit 14 days, which is just an unacceptable number for us as a company. And it's even worse for patients who are sort of desperately seeking care. And to make things sort of extra spicy, this is a cycle, right? So time to balloon and no-show, they were sort of reinforcing each other. As our time to balloon went up, patients were less and less likely to attend that visit. So our no-show rate went up too. And so going into 2023, we sort of knew we needed to address this no-show rate and the downstream impacts. Panicked patients.
Yeah, just a quick question. Was the 14 days, was that a maximum, or I assume it's not an average?
That was the maximum. Our average though was rising too. It was probably around 7 at that point.
Okay, which is still way over the target of 0 to 2.
Yeah, exactly. Yeah, so we knew we needed to address it, right? Again, we sort of started with the standard playbook. We all know that you can try, I don't know, reminder texts and calls and confirmations and all of those types of things to impact patient behavior. We tried all those things. It was barely moving the needle. We were seeing basically no impact. And so we had to look at the more, I guess, sort of aggressive options like double booking or overlapping visits. There are clinics that charge patients for missing a visit, and there are even clinics that discharge patients for missing a visit. Those didn't feel right for us at Boulder. We wanted to think about this differently and try to solve this problem in a way that didn't punish patients for their behavior. And so I started thinking, if I couldn't.
So sorry, Pia, before we move on, sorry to interrupt again. A question from the audience, actually. So
Yeah.
the time to balloon was that, can you provide the distribution new patients versus existing patients?
Yeah, time to balloon is specifically for our new patients. That's not a metric we track for our existing patients. What we're tracking for our existing patients is actually, can we get them their medication, at or before the run out date of their previous prescription.
Okay, clear, thanks.
Yep. So we had to start thinking differently about this problem, right? I can't change patient behavior, or at least nothing I've tried so far has worked. So what if we just embraced it instead? What if we actually listened to what they were telling us with their behavior? And we started thinking, well, okay, what if we back up from the no-show problem? What if the no-shows aren't the problem at all, and it's actually us and how we're rigidly scheduling these visits? Our patients were saying rigidly scheduled appointments don't work for us, and all of the solutions we were trying were just making the schedule more rigid. Why was I trying to solve this problem by just making it worse? So we'd long toyed with the idea of an on-demand visit, and this is not a new idea. I'm not going to claim this as some innovative idea I suddenly came up with. It exists, right? It exists in urgent care or acute care. It exists for affluent patients seeking care at their convenience. But we hadn't seen it done for long-term care for chronic and complex conditions like SUD. And that makes a lot of sense, actually. Our industry, and myself included here, we tend to make a lot of assumptions about what patients need, and those assumptions don't lend well to an on-demand model. Things like the patient needing a dedicated relationship with a single trusted provider, or that patients and their needs can fit neatly into these boxes of 20-minute visits or standard care journeys, and that they can or will organize their lives to show up where and when we need them to be. And in substance use disorder, I want to say that the stigma surrounding this care, I think, makes it even more true that these kind of assumptions drive the care. But if we're willing to re-examine that, there is a case for on-demand care in substance use disorder. What if instead of one trusted provider, we could build a trusted community of providers? Every patient's recovery path is different. And so what if we weren't as worried about the standard care journey or recovery path? And then that care journey or the schedule should really be driven by the patient's needs, not the provider's. Because if you're aiming for low barrier, flexible, convenient care, which is, by the way, a recipe for retention, the patient should be driving it. So we decided to try it. Really, it was one nurse practitioner named Jody who came to me and said, can we just try it with me? We don't have to build any tech, just let's see what we can do without investing. And so we did it that way. We didn't build any tech. We had no training. We just had Jody, who was sitting in front of her laptop waiting to see what popped up in front of her. And we started with patients who had missed visits. So when they called us, rather than, sort of scrambling to fit them into someone's calendar, we just got them on a video visit and we said, Jody's on her way. Just hang out until she gets here. We thought this might be frustrating for patients, but we were wrong. The positive response was really compelling. And Jody was really excited about it. I'm going to just pause and say that I have learned in my time at Boulder Care that if Jody is really excited about something, the best thing I can do is just make it happen. And so together, we started to rally the troops. So this is where our product and engineering teams jumped in. They built a virtual waiting room that we started calling the pop-in clinic. We sort of wanted to differentiate it from your typical waiting room or on-demand care that our patients might have experienced at urgent care or, the emergency room. And so soon, patients who had missed their visit were automatically eligible to join this queue, this waiting room. And once they'd hit the join button, they would just go about their day and then get a text to join their video visit when the next provider was ready. During this time, I played the role of air traffic control. So I kept an eye on the patient queue and I was matching patients with clinicians as they came in and trying to sort of manage this flow so that we could get to every patient within just an hour or two. And the reason for that was what we didn't want to do was have patients waiting for, 8 hours to see a doctor for 5 minutes, right? That's not going to be a positive experience. We didn't want to replicate that. And so I was sort of manually trying to see, well, okay, if we have, 2 hours of capacity, how many patients can I get in the door and get seen quickly? And soon, as we sort of got our feet under us, we started asking all of our clinicians to take shifts in the pop-in clinic. Because their feedback was going to be critical in building something that they would all embrace. And they did. They had a lot of feedback along the way on how to make it easier for them to grab a patient or how to adjust the chart so that they could get the information they needed quickly. I saw a lot of questions coming in about staffing ratios, and I've warned Rick that I could spend literally hours just on this topic alone, and I'm going to try to keep it concise here, but this is where we started spending a lot of time trying to figure this out, right? So I knew what 1 hour of clinical capacity could do in a scheduled world. I had to learn what it could do in a pop-in world. And I used that air traffic control role to help me understand that, right? My eyes were glued to the queue all day long. And so I could sort of start to see and start to look at the data and see like what would happen with that same hour of availability. At this point, we were still just doing follow-ups for patients who had missed their visit. And I saw a question in the queue. That's where we were at this point. But one day, it was a couple months into this, Jody came to me again, and she had had, I think, 2 scheduled intakes no-show back to back that day. And she said, this isn't going to work unless we crack the code on intakes. And let's try it. And so we did. We said, okay, we're ready. It took some tweaking, right? We had to make the process a lot easier for new patients to understand. They didn't have context on Boulder, on who we were and how we worked. And so we needed to tweak the process so they knew what to expect. But as we figured that out, it was so successful at getting our patients seen quickly that it felt like it just within weeks we were doing all of our intakes in the pop-in clinic, and time to balloon was back down to 0 to 2 days.
Maybe can I ask like a
Yeah.
quick question here? So we might have people now trickling in or listening and think like, oh heck, I also want to pilot this, but they might not have a Jody to relay this. So can you like share some of like the challenges that you encountered when you tried to sell this concept as a pilot to their clinicians, and how you overcame them? Because I'm a nurse, and whenever someone pitches me something new I need to do, I will say no. Unless you give me like very, very good arguments. And even then I will likely say no. So like any learnings there that you can share?
Yeah, absolutely. Jody was a member of our clinical leadership team. And one of the things we did early on was start bringing the 3 of them in, not just Jody herself. And so we had them as sort of our advocates for, hey, I've been working in this model. I've been seeing patients in this model, and that's been working really well. But the other thing that we did that I think was really successful is when we first started testing and expanding it to more clinicians, we did it on a volunteer basis, right? And so you're always going to have 1 or 2 or 3 clinicians who are really interested in testing something new. At least that's what we found, is there are going to be folks on your team who want to try the new thing and want to get involved. And they became our sort of cheerleaders for this. And one of the ways we sort of bridged the gap happened pretty organically is we sort of we kind of made this a party because we were using a Slack channel to manage all of the clinic flow, the queue. It sort of became the fun place to be. It was like you did your regularly scheduled appointments, and then you got to go spend an hour or 2 in the rodeo where Pia was madly trying to match people and anything could happen. And so it just made it a little bit of a fun opportunity for folks. That doesn't mean we didn't have folks who were nervous about it, who didn't love the experience at first. Of course we did. But as they got more and more accustomed to it, and we sort of kept building things that made it easier for them, we were sort of able to bridge that gap.
And so in terms of workflow, so you mentioned Slack. So how does it then go? Like, I'm a patient, I get into your queue, and then you try to match me, and then I get a text, and then I get a Google Meet link or something? Or how does that, like, how did the workflow go?
Yeah. In the early days, what would happen is you join the queue, and the sort of directive to clinicians was just take the next patient in the queue, right? As soon as the patient accepted the visit, or sorry, as soon as the provider accepted the visit, then the patient would get a text and they would go to their app and have a join link, join video link to go to. While the provider was waiting for that patient, they would prep for the visit, right? They'd review the chart. And so that was one of the things we actually had to sort of fix, was it's got to be easier to prep for your patient if it's a patient you haven't seen before. That's very similar to the way it works today, but of course we've built lots more things like, estimated wait times and things like that. Did that answer your question, Rick?
Yep. And I'm looking forward to the next slide because you will answer many questions that people have in the chat. By the way, the first time that we have so much engagement in the chat, so you're doing an excellent job.
I hope that's a good sign. Okay, so we're doing intakes in the queue now. Time to balloon is hitting 0 or 1 or 2 really consistently, and we are thrilled. We know we've got something, right? But yet again, I had caused another problem. Our no-show rate was going up. So I was mystified by this, and we started digging into it. And what we learned was patients were so happy with the care they were receiving on demand that they were just missing their scheduled appointments to come to on-demand care. We had trained them that on-demand was easy. And
were you advertising the on-demand at this time?
We were not advertising, but our patients who had missed a visit and used on-demand knew that they could do that again.
So quick behavior change is absolutely possible in healthcare.
It is, if you're providing a positive experience.
Yeah, that's a great learning.
Yeah, absolutely. Okay, I have created more problems than I've solved at this point, which is a little bit the story of my life. But we started thinking, like, God, have we accidentally cannibalized our own business? And are we at the point where we just need to go all in? So we took a step back, a brief step back. We looked at what we knew at that point. We'd been testing for maybe 5 months at this point, and we could say our patient and provider feedback is overwhelmingly positive about the experience in Pop-In Clinic. But providers are getting more frustrated as our no-shows are increasing. One, because they know there's another option now, but 2, we were asking them to split time between paneled care and Pop-In care, and they were running out of space for their paneled care as the demands of pop-in clinic rose. And so they were getting really frustrated. On a positive note, we were seeing that our outcomes and quality metrics hadn't changed, so we knew we could deliver high quality care, whichever model we were using. And we knew that running both models at once at this point was becoming untenable. Something had to change. We wanted to continue to expand pop-in clinic by testing and iterating now with patients who would only be seen in pop-in clinic. They wouldn't have that scheduled visit first that they had to miss to get into the pop-in clinic. But to test that, we needed our patients to opt in. And that is, at least in my experience, a really hard thing to accomplish. Patients were really hesitant to sign up to test something they didn't quite understand. So in September of 2023, we decided to just take the leap. I am not going to lie, this was a scary decision. We had really positive but really limited data, and we had a lot left to learn. But we also knew that if we waited too long, we would just lose the moment. We'd lose our care team's buy-in for this new model. They'd just be so burned out trying to juggle both. It would be even harder for them to sort of bridge that divide. And I want to take it back to our mission here. If our mission is to increase access to those who need it most, this decision to take this leap starts to make a lot more sense, right? In the face of sort of seemingly endless demand for addiction care, it felt like if we believed we could expand access, then it was our duty to go for it. So we could sort of see this promise, but it really did mean uniting together and taking a risk.
Did you do kind of a pre-mortem before you took the leap? And what was maybe the couple of takeaways from that pre-mortem, if you did one?
Yeah, we were looking really closely at NPS data from patients who had had a pop-in visit versus patients who hadn't, and seeing that it was actually slightly higher for patients who had had an on-demand visit. And that was a really good indicator for us that this was going to sort of work. And then we were also looking at how were our patients who had done their intake in on-demand doing with their scheduled visits. And they were actually missing their scheduled visits, I think because their first experience with us was on demand. And so then we were asking them to change how they engaged with us. So all of that to us said, we've got to have one model, right? I want to talk a little bit about this 5-week transition, and I want to acknowledge fully that this was crazy. It was, I think, a wildly audacious thing to do, but we knew that drawing it out over months was just going to lead to sort of these endless cycles of second guessing. And it felt like once we knew what the future could look like, our job was to just get ourselves there faster. And so while it was stressful, and I will tell you that a lot of my colleagues still give me some crap about it to this day, in many ways, it actually was a gift for a couple of reasons. One is it forced everyone to focus on this one overarching goal. And I can't stress enough how important that was. There were simply no distractions along the way. And then equally important, it forced us to be totally ruthless about what features needed to be and could be in place before the cutover. I will tell you, I was still managing the queue at this point with help finally from a team of people who were also taking shifts. But after doing this for so long, I had this really sort of wild list of features I wanted, and they were really complex. If any of you remember the movie Minority Report with all the screens in front of Tom Cruise and he's moving things around on all the screens, I was literally describing that to our product managers who are all a lot younger than me and had never seen that movie, and saying, like, this is what I want. Or I want like a DJ mixing board that I can dial up and down all of these inputs at any given moment. And luckily, they talked me out of all of that and said, what if we just programmed that into an algorithm for you? And that's how we ended up with Otto the algo on this screen. And then we built two other things, or did two other things. We shored up all the infrastructure that, we had pilot infrastructure. We needed to shore it up for more volume. And we automated queue eligibility and messaging for patients. So we knew, based on our data and the scripts that we wrote, when they were set to run out of medication. And around that time, we would make them eligible to come back to the queue, and we would start messaging them to say, like, hey, your run out date is in a few days, come on back to the queue.
Can you talk a bit more, without spilling any beans, Pia, talk a bit about Otto the algo, or maybe that's coming in the presentation, but like, for example, what are the inputs that went into the algo? How often have you tweaked it since? And what does the algo actually do? Does it just put a patient at the very top of the list, and does it then stack rank all of the patients after each other? What does it do?
Yeah, it basically just manages our queue capacity. So, we'll program rules into it, and then it will figure out how to sort of manage the patients in the queue based on those rules.
Yeah, and can you talk a bit about the inputs for the algo?
Yeah, I want to be a little careful that I don't dive too into the weeds here, but basically, we're always updating inputs based on what we learn about capacity.
Okay, good. There is some secret sauce in there, which is perfectly fine. I get it. You don't want to divulge everything.
Fair. Okay. Let's talk about the transition. I can't lie. It was pretty rocky. Our patients struggled with the change, right? We knew they would struggle with the change. They were frustrated with having to join a queue when they'd previously had a scheduled visit. They were nervous about meeting a new provider for the first time. And our providers and our care team members also had a big adjustment to make. Things were a little bit tense. But we also knew we had trusted our ability to sort of learn and iterate rapidly. And our product and engineering teams spent, months rapidly iterating based on demand data and patient and provider feedback. Our ops teams filled in the gaps manually until those tools got built, and our clinical leadership team were very sort of steadfast in their support of the goal and our teams. It was all hands on deck, and I do want to say that I am so grateful to the teams that helped us pull through this. One of the questions I saw come in was, what metrics did you look at to know that you were on the right track at this point? And NPS was a key metric we looked at because we knew it was going to change most rapidly. And we knew it might drop in that first month if patients, were adjusting to a new system. And we set a floor for when are we going to re-examine our commitment to the pop-in clinic? What does it have to hit to make us do that? We set that floor, and that first month, our NPS came pretty close to that floor. And so in month 2, in December, we were all eyeballs on NPS. We knew December was sort of our make or break month. But we were adding more features to improve the experience, and patients got used to the new model. They met that new provider, and they got the same empathy and kindness that they were used to. And our NPS started ticking back up again. And I'm really proud to say that it stands at 86 now, which is, as high as it's ever been. And a year later, we've seen so many of our metrics catch up to that as well and prove out. So, double the patients served year over year. At this point in January, actually more than 2x monthly enrollments. Our care team satisfaction is up as well, and I'm really pleased to say our retention is up too. Okay, so we're a little more than a year after launch. Here's where we've landed. Almost all of our appointments are through this pop-in clinic. Our wait time, we're averaging less than an hour. Our time to balloon, we average, a day or less. and patients are getting care on their schedule, not ours. And where we started with all of this, no-show rates and time to balloon, they were two of our biggest pain points. And now I have to admit to you, sometimes I just forget to check them because they're just not a factor anymore.
Can I maybe, so first of all, these results are insane. And thank you for all that you have done for patients and your leadership. I do have a question. So in the beginning of your presentation, you mentioned like we as humans tend to make wrong assumptions. And so one of the wrong assumptions that I would make as a nurse is like, I would see this model and I would say, yeah, but patients care about seeing the same clinician every time. So because I build a relationship with Pia, so next week I don't want to talk to Thomas. And based on our previous conversation, it seems that this assumption was wrong. So can you maybe tell a little bit more about your learnings there and like how you and your team became more comfortable being wrong in assumptions and not and stopping making assumptions for patients and just like testing it out more? Yeah.
Yeah, I want to say that, what we learned, our assumption was that patients would want to see the same clinician. And I think that's still true for many, right? And that might be true in another environment. It's really specific to your care team. And so this has worked for us. I don't know that it works for everybody, but it certainly was something that we had to re-examine our assumptions about.
Yep, that makes sense.
Yeah, and we do work in a team-based model for sure. And we also have smaller cohorts of clinicians so that we can actually make sure that we're sort of practicing in a community at the same time.
Yeah, another question. So I assume that you need to get these patients in at a regular cadence. How are you handling that? If you're leaving if you're leaving everything on demand and to the patient, that obviously will they will miss some of that cadence. So how are you handling getting them in at the right points in time in their overall care journey?
Yeah, like I said, we manage a lot of this through automated messaging and reminders to patients, and knowing and trusting that our patients are also going to come to us when they need us, right?
So is there an aspect of utilization there that you're optimizing?
Yeah, I could dive into utilization for basically ever for hours. We are certainly managing our utilization by looking at when do we expect patients to come in based on their run out dates and on new patient demand. That is all data that we look at to sort of try to figure out how much clinical capacity we need.
So what I love about this, and I mean the comparison might be totally off here, but it reminds me of McDonald's through the data of their decades and decades of understanding when people are going to come in. They actually already know how many burgers need to be in the process of being ready for people to come in, right? And so that's obviously the unique data set that you've built with your capacity, your clinicians, and your patient population that allows you to continue to refine that over time.
Yeah, I think that's exactly right.
Cool.
Okay. Rick, you asked me to talk a little bit about, failures and learnings. I'm going to actually skip our next slide because I feel like I've answered a lot of those questions along the way, which is great. But I will just say that, we the big learning for me was to sort of reevaluate our expectations all along the way, right? Reevaluate our assumptions and not be scared to look at the data with an open mind. That to me was the most important thing. The last thing I sort of want to leave you with was, our patients. This has been all about our patients from day one. And I want to leave you with maybe just one sentence from a patient that has stuck with me since we got it back in an NPS comment. I know they're there when I need them instead of having to be there when they need me, like every other doctor. That's what I sort of stick to as we think about our pop-in clinic. Okay, I'm going to stop sharing my screen and, Rick, please guide me.
First of all, thank you for this presentation. Again, the amount of engagement that we see in the Q&A and in the chat is insane. And also an invite to everyone in this room that is here today and asking all of these questions. Please start open sourcing your knowledge as well, because we're all in it for the patients and we have a commitment to drive better outcomes. So don't bury your secrets and be like Boulder and share some of that knowledge with the audience, because that's why CareOps exists and that's why we are doing what we are doing today. And related to that point is, it seems like the success of the pop-in clinic is like a strong collaboration between not only operations, where you are like the traffic controller, also clinical, and then also engineering. So how have you, as an organization, created a culture where there is like no silos and more collaboration between those teams?
Yeah, it's such a good question. I think it's so important that our teams are all working towards the same goal. That is maybe the biggest thing, right? You can have all the process in place that you want, but if you're not all working towards that shared mission and shared goal, I don't think the process necessarily helps you. And so for us, we've built a lot of trust among our leadership, and we really work to make sure that we're all pointed at the same things.
Yep. We have 2 more minutes, and I don't want to take more of your time because you already told so much, shared so much, and I'm forever grateful for you doing this. Maybe the last 2 minutes, Thomas, for you to talk a little bit about the conference that is coming next week.
Yeah, we're stoked. A couple of years ago, Rick and I started writing about CareOps and then organizing these webinars. And next week is our very first CareOps conference in Nashville. We're looking forward to an amazing 2 days of people coming together talking about CareOps. And we will obviously share a lot of the learnings and the tidbits during the conference and afterwards. But it's going to be amazing to bring this community together in real life. It's all scheduled, no on-demand pop-in. Unfortunately, maybe we can try that out next time. But thanks, Pia. This was amazing. I think, beyond your competitors, I think there were also a lot of people in, primary care, health systems, etc., in the audience. And so it's now up to them to figure out how they can, try this out for themselves. So thank you for the learnings.
Thank you so much.
And thank you for your leadership. Have a wonderful rest of your week.
You too. Thanks, everyone.
Bye-bye.
Thank you. Bye.